Hello, my name is Karen Warburton, and I am a transplant nephrologist at the University of Virginia. I really appreciate the offer to speak on the topic of remediation, and I'm sorry that I can't meet all of you and give the talk in person. So I've been involved in the remediation of struggling learners at both the graduate and undergraduate level for many years, and I currently run a GME-wide coaching and remediation program at the University of Virginia. I have no disclosures relevant to today's presentation. And I thought I would start by sharing some of the lessons that I have learned along the way, and then review some practical points about the assessment and remediation of the struggling learner, and finally touch on some aspects of building a remediation program. And I will include my contact information at the end of the talk, and I encourage anyone who has questions or wants to talk about remediation to please reach out. So though it may be stating the obvious, I think it's really important to remind ourselves up front that learners struggle. Because if we cannot admit this to ourselves, we won't recognize the struggle early enough to really make a difference. Most of the data on the prevalence of struggling GME learners comes from surveys of program directors across specialties, and I've listed these references here. And the prevalence varies widely and depends obviously on how you define struggle. But in the literature, it's typically reported to be between 5 to 15% of learners. And this has been my experience as well. And this is residents. There really aren't systematic data on fellows specifically. And I think it's even less clear how often medical students struggle, as most of the literature in UME is really centered around test performance. Okay, so learners struggle, and I just want to make the point that early recognition is so important because remediation takes time. And unfortunately, there's often a delay in our recognition, or at least our willingness to admit our recognition of struggling learners. And I think there are many reasons for this. Time is probably the most important of these. There's also perceived stigma to the learner, sometimes a lack of comfort or skills, logistic challenges, and for some, a fear of retribution. So I think that improved recognition often requires a culture change, and this may need to occur at the institutional level. And that is that we accept that a certain proportion of our learners will struggle, and that it's our job to put into place the resources necessary to remediate them. Success in a remediation program really hinges on accurate determination of a specific clinical performance deficit or deficits. And I put the term diagnosis in quotes here because we obviously never want to be in a position of diagnosing our learners with anything. And this accurate determination requires a systematic assessment process. And I'll come back to what I mean by that in a bit. Probably the most common learner chief complaint that I see is needs to read more or struggles with medical knowledge. Usually this is a signal that something is wrong, but it's often not knowledge. And for these folks, much of our assessment is focused on differentiating a true knowledge deficit from a clinical reasoning deficit, and we'll come back to this in a bit as well. Another common source of referral is the learner who is noted to be disorganized or inefficient. So what does it mean for a learner to be disorganized or inefficient? I've kind of created this differential diagnosis over the years of working with many of these learners. For some, this is a true problem with organization or time management, and often there are clues to this in the interview. I often ask if the learner pays his bills on time or what her desk looks like at home. There may be specific issues related to the system in which the learner is operating in residency. Maybe they're unfamiliar with the EMR, or maybe their prior program didn't prepare them for the volume and acuity that they face in the current program. And coaching for true organization and efficiency issues focuses on teaching the learner systems that can be used to complete the daily work. And we've published on this. Often peer coaching can be useful in this case. Probably slightly more commonly, though, the resident who appears disorganized actually has a clinical reasoning deficit. And the apparent disorganization is really their inability to gather data effectively and efficiently in a compressed time frame. Clinical reasoning coaching looks quite different from coaching for organization and involves some diagnostic work to identify the lesion in the clinical reasoning pathway, and then work on exercises that target that lesion or lesions. And then finally, disorganization or inefficiency can certainly be the single presenting sign of an underlying issue with mental well-being. So I think it's so important to differentiate between these underlying causes because the coaching looks completely different in each of these cases. So our program at UVA is called COACH, and this stands for the Committee on Achieving Competence Through Help. And I'll refer to COACH and our process throughout the talk. Happy to speak offline with any of you who are interested in hearing more about COACH. This flow diagram illustrates our process. And I'll say that this program is based on a program that a group of us developed at the University of Pennsylvania in 2014. Which is where I was before I moved to UVA in 2016. And this program is described in a couple of publications from Penn in the Journal of Graduate Medical Education. So in COACH, learners are referred, and we have a comprehensive assessment process. And our assessment team assigns a primary and/or secondary clinical performance deficit as categorized here. And we'll come back to the assessment and coaching process a bit later. But first is our third lesson from remediation here, and that is that underlying issues are common. So learners who struggle with clinical performance often have a lot going on under the surface. And often if you don't ask directly, you may miss some of these things. So I think it's important for every struggling learner to consider the things on this list. This is sort of a list that I've compiled over the years of working with folks. It's not that everybody has one of these things, it's just that if you don't ask about it, you may miss. So the first is stress, and I think there are many types of stress that affect learners in their 20s and 30s. Probably the most common is family-related stress, but of course there's also stress related to careers and finances and health. The spillover of problems in any of these areas into work is really very common. Of course, anxiety and depression are also common among struggling learners. Personality disorders or features of personality disorders may underlie certain types of struggle, particularly those related to professionalism. Impairment is always something important to consider when you see a learner struggling, and there are many types of impairment beyond just substance use. There's fatigue, medical illness, and this comes up from time to time. Cognitive dysfunction or learning disorders may underlie certain performance deficits, and it's always important to consider these. I'm working with several learners now with ADHD. For some, this is a new diagnosis, and for many, this is a diagnosis made or considered when they were young. For many, there is some stigma to this diagnosis, and for others, it's such a relief to be given this diagnosis. But it does come up not infrequently. And I should just point out, when I said earlier that it's important to ask about these things, I don't necessarily recommend that the program director be the one asking these questions. And one of my goals in creating a COACH at my current institution is to provide a safe space for learners to discuss these issues and disclose these things, and to learn about specific resources in a confidential environment. And then I add just some other contributors such as burnout. Some people make the wrong career choice or in the wrong program. And sometimes our program is able to provide support related to career or program redirection. And then I've begun to make this list of personal attributes or characteristics that I have found often contribute to the likelihood that a learner may struggle, and certainly that influence a learner's ability to respond effectively to coaching. These are things like maturity, reliability, honesty, ability to reflect, insight, willingness to change. Insight and ability to reflect are two of the most important prognostic factors for successful coaching and remediation. I've found that struggling learners often have trouble identifying feedback or can't actualize the feedback that they're given, and they tend to have blind spots. Part of our process in COACH is to help them better incorporate the feedback that they're getting from evaluators. We've found at UVA that nearly 40% of learners referred to COACH have an underlying mental health concern. And in our experience, this is most commonly anxiety, followed by depression, then with a handful of folks with ADHD and other conditions. Among struggling learners with underlying mental health concerns, professionalism is the most common type of clinical performance deficit, followed by clinical reasoning, organization and efficiency, medical knowledge, and communication. Okay, so moving on from lessons learned to thinking about how we approach the assessment and remediation of a struggling learner. And these are principles, although I focus on GME in this talk because that's where I do most of my work, I think these principles can be applied across the continuum. We're actually building a program at the medical school here. I have run a remediation program for students at Penn, and I think, you know, there are more similarities than there are differences. So for coaching and remediation to be effective, we really have to make sure we really understand what the problem is in the first place. And this can take some digging. So we spend a fair amount of time on the assessment process in Coach. And this is an approach that we developed at Penn. And the publication referenced here was a description of this program at Penn. And again, it's very similar to what we're doing at UVA. And I just want to clarify that when I use the term assessment here, I'm just focusing on the assessment that we do in the coaching program, which is really just done to inform the coaching process and not to inform the learner's milestones. We take very seriously this separation between coaching and true assessment or evaluation. So our coach assessment has two phases. There's what we call the reconnaissance phase, which involves a review of the learner's written file, review of performance in the prior program if it's available. And then I typically like to talk directly to people who have worked with the learner. Ideally, it's helpful to directly observe the learner. And while I rarely do this in the clinical setting, in the GME setting, given concerns for stigma, we do, when possible, do this in a simulated setting. And we can talk a little bit more about this when we talk about the actual coaching in a bit. And then we typically do a 60 to 90 minute interview with the learner. I do most of these, and then I have trained some other faculty to do these on our assessment team and Coach. And during the interview, we really just try to get to know the learner and understand their perception of the problem at hand. So just to go back to our differential diagnosis, I'm going to focus the next few slides on the assessment specifically of medical knowledge, clinical reasoning, and professionalism, because these are some of our more common areas of concern. So Coach's assessment of knowledge is actually pretty straightforward. I think of all learners as having a tank of knowledge, and for some that tank is just more full than others. Direct observation, content-related questions, and discussions with evaluators are all very helpful. We always review the learner's performance on standardized tests, going back as far as necessary. And in the interview, we ask about study habits, specifically how much studying, how effective is the studying. Often there's just a lack of committed time or there are distractions. We ask about history of learning disorders and mental well-being issues, as previously discussed. I talk to the learner about whether their test performance in the past actually reflects their knowledge. We review the trajectory. Have they always struggled, or was there an abrupt drop-off in scores or performance? Is the knowledge deficit global, or are there specific areas of concern? I like to review the in-training exam scores in detail if they're available. And then I always ask about the role of performance anxiety or poor self-confidence. I've worked with many learners who have plenty of knowledge in their tank, but they tend to freeze on test day or on rounds. And in these cases, we've found that cognitive behavioral therapy and mindfulness exercises can be very helpful. One of the most important distinctions is differentiating a medical knowledge deficit from a clinical reasoning deficit. Clinical reasoning problems, in my experience, are actually much more common among graduate medical learners than true knowledge issues, and they often get mislabeled as knowledge issues. Clinical reasoning is really the application of one's knowledge in an actual patient scenario. And these are common observations of learners who struggle with clinical reasoning. So learners almost invariably struggle with patient presentations. Many evaluators may comment that the learner can't see the forest for the trees or that they don't get it. Learners may struggle with summarizing their patient in a succinct one line. This skill is known as problem representation and is a key part of diagnostic clinical reasoning. They may order too many tests. They may struggle with creating or prioritizing a differential diagnosis. They may have trouble structuring a clinic visit or an admission or a consult, and therefore appear disorganized or inefficient, as we talked about before. Many of them can't triage a task list. They may have trouble recognizing sick versus not sick, or behaving or responding appropriately in urgent situations. This is management reasoning. And not all faculty feel comfortable with this as a concept, clinical reasoning, or have the language handy to describe clinical reasoning issues. And so we end up doing a lot of faculty development and a lot of assessment in the coach's office to really tease out these issues. So typically we break the diagnostic clinical reasoning pathway down into these components. So generation of hypotheses, data gathering, problem representation, pattern recognition, and illness script retrieval, and then script selection and diagnosis. So when a clinical reasoning deficit is suspected, our coach assessment typically involves some simulated work through cases to identify the lesions or lesions in this pathway. Okay, moving to professionalism, which is often a topic that makes people cringe. It's actually one of my favorite areas to coach. Professionalism is really a heterogeneous category that encompasses both behaviors and character traits. I tend to group the issues into these categories, but there are obviously different ways to think about it. So learners can struggle with interpersonal skills, then there are issues with rule breaking, the lying, cheating, stealing types of behaviors. There's the trainee who doesn't take ownership or is unreliable or doesn't know his or her own limits. And then there's kind of a separate, more egregious category of things like sexual misconduct or abusive behavior. And I can't stress enough the importance of understanding the why in cases of learners who struggle with professionalism. So if you concentrate on the behavior without exploring the origins of the behavior, it may be very difficult to actually help the learner. So here's some examples to illustrate this concept. These are common types of behaviors that come to coach under the professionalism label. So first, let's talk about the learner who doesn't respond appropriately to urgent situations. So occasionally this is truly a professionalism issue, that of laziness or unreliability. But there are additional explanations for this type of behavior. So as I mentioned a couple slides back when we were talking about clinical reasoning, maybe the learner has a knowledge deficit or a clinical reasoning deficit, and they don't know how to respond, or they don't recognize that a situation is urgent. Maybe the learner has performance anxiety. I had a learner who was actually really smart and had a tank full of medical knowledge, but would freeze in a code situation. And this turned out to be purely a performance anxiety issue. And he's responded really beautifully to cognitive behavioral therapy and is now doing great. Less commonly, maybe the learner in this kind of scenario is on the spectrum and doesn't understand urgency and doesn't respond to cues the way a neurotypical learner might. So what about the learner who's consistently late or doesn't show up? Certainly this too can be a professionalism issue, but it can also be a lot of other things. This may reflect burnout or impairment, whether medical, substance use, or fatigue. Maybe this is a person with organization or time management issues. And there are many other potential explanations related to mental well-being. And finally, how about the resident who is rude to the front desk staff in clinic, or who loses her temper easily with nurses? We've all worked with or potentially even been this resident. And so often I work with people like this who are just advocating for their patients, or who possess features of the compulsive triad that is so common among physicians, who are perfectionists, or whose own families talked to them in this way and when they wanted something done, or physicians who are burned out or depressed. So you really have to dig beneath this behavior to understand what's going on. Okay, so moving on from assessment to the coaching and reassessment itself. So some of you may be familiar with Karen Hauer's model. So Karen Hauer is at UCSF and developed this model in a paper quite some time ago, actually back in 2009. Proposed this as a model for guiding the process of remediating the struggling learner. And this model has really provided the framework for most of us who have published on remediation to develop programs. So University of Colorado, University of Pennsylvania, and UVA. And this model begins, as we've talked about, with a comprehensive assessment of the learner, followed by diagnosis of the deficiency, development of an individualized learning plan, and then the remediation itself. And all of this, of course, requires an effective relationship with a mentor or a coach. Then following remediation, there's reassessment and certification, hopefully, of competence. And I want to make the point here, if I haven't already, that the reassessment at the end should ideally be done by someone who has not been coaching the learner. Typically, in my experience in the GME level, reassessment is done by the CCC. In our model and in my experience, coaching and assessment should be separated. I think I've made that point a few times now. So in Coach, our program develops an individualized coaching or learning plan. We start with 3 to 5 specific measurable goals that are also hopefully attainable, relevant, and make sense within the time frame of the coaching or remediation period. And typically the time period is spelled out by the clinical competency committee or the program director. Our program typically lays out where the coaching will take place. It often begins in someone's office, for instance, a clinical reasoning coach or a knowledge coach or a professionalism coach. Then we move to the clinical learning environment once some basic diagnostic work is completed and the skills are introduced. The simulation center, as I mentioned before, can be a tremendously effective environment in which to coach learners, not just for procedural skills, but also for things like communication and professionalism. The coaches may be domain experts or occasionally are peers. Again, typically peer coaching is used for coaching organization and efficiency. And then once the learner's coaching plan moves back into the clinical learning environment, we involve the evaluating attending of record. As I mentioned, the timeline is typically laid out by the program, both the timeline for coaching and the timeline for reassessment. And I will briefly outline the principles of coaching for each of the 3 areas we focused on so far today. So medical knowledge, clinical reasoning, and professionalism. So medical knowledge is typically the easiest of the clinical performance deficits to remediate and generally has a pretty favorable prognosis as long as the learner is engaged and any potential underlying contributors are correctly identified and appropriately managed. But a knowledge remediation plan typically needs to go past just read more, which is often the advice that learners get. And most learners who struggle with medical knowledge have failed to find that reading more helps their knowledge deficit. So the assessment typically gives us a lot of clues as to what the problem is, whether it's not enough studying or ineffective studying. We assess for distractions and try to mitigate them, study habits, and examining test-taking experience, as we talked about before. We typically establish an objective. A common one in GME is working toward the next in-training exam or the boards. And learning really should typically be symptom-based rather than disease-based to better simulate how the learner will encounter patients or test questions. We like to identify a coach or coaches and have the learner develop a list of clinical questions and then research these questions and present the list, the reading plan, and ultimately the topic presentation to the coach. The topic should be as closely linked to the learner's rotations as possible. We assign questions, standardized test questions, ideally contextually, and the learner should review their incorrect answers with the coach. And these strategies tend to promote retention and tend to make learning a little bit more fun. We found that clinical reasoning is a very common area of struggle among graduate medical learners. And we've developed a clinical reasoning coaching program at UVA. This is led by my colleague, Andrew Parsons from the Department of Medicine here at UVA. So Andrew and I lead a group of 13 faculty members here from 8 different departments, and our mission is twofold. We have been trying to train members in a standardized approach to the diagnosis and coaching of clinical reasoning deficits. It's really been interesting to think and brainstorm about what a clinical reasoning deficit looks like, say in a surgery learner compared to an anesthesiology learner compared to a pediatrics learner. And there are many similarities and obviously many differences. And then our second goal is to aim to develop durable materials that a variety of academic departments can use for coaching and then hopefully publishing these materials. And we've had a lot of fun developing assessment tools and coaching tools and have a lot sort of ongoing. So this is a really busy slide that hopefully illustrates our approach to problems with diagnostic clinical reasoning. As mentioned earlier, the coach in our program works with the learner to identify the lesion or lesions in this pathway from hypothesis generation to data gathering to problem representation to refinement of hypotheses, finally to development of working diagnosis. And then we've identified exercises targeted at each step of this pathway that we can initially These can initially be undertaken in the coach's office and then later in the clinical learning environment by the supervising attending. And there's so much more to clinical reasoning that is not depicted here. We're working on tools, as I mentioned, to assess and ultimately coach management reasoning, specifically recognition and response appropriately in urgent situations. So lots more is coming soon. And again, I'm happy to go over any of these with any of you who may be interested in developing a clinical reasoning coaching program. So moving on to my favorite topic, which is remediating professionalism. So I want to briefly introduce a very simple framework for understanding professionalism issues that was given to me by one of my mentors at Penn. Her name is Carol Zoe, and she's an amazing clinician, teacher, and coach. So she separates learners who struggle with professionalism into can't, won't, and oops. So can't refers to a person who behaves unprofessionally because he or she hasn't learned the norms, professional norms, or doesn't know the rules, or is having trouble following the rules despite very good intentions. So this could be someone from a different culture, either who's lived in a different culture or trained in a different culture, or someone who learned this way of behaving in their own family, or potentially someone who's struggling with mental well-being issues such as depression or anxiety, or has a processing issue. Won't refers to someone who very well knows the rules but chooses not to follow them. And this might be somebody who's operating out of love or lust or greed or mania. And oops is a mistake. We all make these. So oops, the oopses are typically managed by supporting the learner and examining the learning climate. The can'ts these are the people that really tend to respond well to coaching. And in these cases, it's important to be very specific about goals and to set boundaries, to teach norms. We do a lot of work with narrative reflection for cases of can'ts. And many of these folks, as long as there isn't an unresolved underlying issues, many of these folks do respond well to coaching. And then finally, the won'ts. These are the folks that really need discipline. They need consequences. They need the talk that their behavior will be career limiting if it hasn't been already. Often these folks get a letter in their file or are placed on disciplinary action and probation, or may even be terminated from the program. So I found this to be a very simple and also very helpful way to think about professionalism issues. So I just included a sample learner. This would be an internal medicine subspecialty fellow. So this is a fellow who the Medicine Clinical Competency Committee placed on formal remediation due to a failure to appreciate urgency in situations of critical illness, inability to identify major clinical changes requiring urgent intervention, and then this is also a person who struggles to report data accurately. So the coach assessment in this case ruled out mental well-being issues using the list that I had provided earlier, and identified in this learner just a general lack of insight and a general unpreparedness for fellowship. This is a person who was at a fellowship at an academic quaternary care center, had trained at a very small community-based program with a low patient census, a pretty low patient complexity. Medical knowledge was below average, and we found that there were lesions at multiple steps of the clinical reasoning pathway, all of which were listed here, both on the diagnostic and the management side of reasoning. And this is a really busy slide that I'm not going to read to you, but for those of you who are interested in how we might compose a plan for someone like this, this outlines some goals and then a plan that was aimed to improve this learner's medical knowledge and clinical reasoning. And again, for those of you who are interested in creating plans or learning more about knowledge or reasoning coaching, I'm happy to talk with any of you by phone about how to do this. So I want to address this idea of building a remediation program, because that is something that I know many people are interested in, and we've done some workshops on this nationally. I think that, I'll start by saying I don't think there's a one-size-fits-all model, which is why I have left this until the end, but I want to just offer some general points and say that a lot of these things are very institution dependent. And again, say that I'm very happy to talk with any of you individually about how to do this. So I want to just start with a word on terminology and just kind of address the terms remediation and coaching. And I note that I've used them somewhat interchangeably in this talk, and I often do that. So, you know, the term remediation really means something very different at different places. Here at UVA, we have a specific GME policy on remediation. Here, this is a pre-disciplinary process that's really designed to help the learner. But I think even here, knowing all of these things, the term may carry some stigma. And at some institutions really does connote disciplinary action. And the term coaching also means different things to different people, and it means different things in the literature. But here in our process and in this talk, I use it to mean individualized mentorship and guidance from an individual who is committed to the learner's success, and this is important, and is not directly involved in the learner's reassessment, i.e. is not the program director. And again, as I mentioned, one of my goals in developing Coach has been to create a process that encourages early identification and referral of trainees before remediation is necessary. So for us, the referral process works something like this. We have two routes for a learner to get to Coach. So a learner can self-refer to Coach at any time. And in this case, nothing is shared with the program leadership and nothing is kept in the learner's file. And I would say people tend to self-refer they refer for different reasons, but often it's people who are dealing with burnout or mental well-being issues, or maybe there are clinical performance issues that just haven't reached the level that puts them on the radar with their program leaders. And frankly, we love self-referrals because I think, to me, this says that we are beginning to move the needle with regard to the stigma and the messaging of our coaching program. And again, it's always easier to work with the learner who is somewhat under the radar with their program before it becomes such a big issue. More commonly, learners are referred to us by their program director. This may or may not be part of a more formal remediation plan. And in this case, at UVA, we do communicate our recommendations with the program leadership. And we are very transparent with the learner about what is being shared and with whom. Again, what goes in the file and where the file is stored really varies depending on the institutional precedent and rules. So I really think that there are three big considerations when you think about setting up a centralized remediation program. One I brought up earlier in the talk, and that is around changing the culture around remediation. For most of us, this means that we have to think carefully about how we advertise the program and how we message the program to learners and to program leaders, so that it's really seen as a resource to help learners rather than as a program to discipline them. So ideally, you want to design a system that facilitates early referral. You have to think carefully about what to call the program. At Penn and at UVA, we've tried whenever possible to use the term coaching rather than remediation when describing the work that our coaches actually do with learners. We've made it largely a voluntary process, and we really try to maintain strict confidentiality with issues related to mental well-being in particular. And I think for us, this has encouraged our learners to self-refer to the program. And as I mentioned, I may have mentioned, we've seen an increase in the number of self-referrals in the last year. Self-referrals now make up almost a third of our total referrals. And again, this tells me that we're moving the needle on the stigma piece. So next, you need to think about what resources you need. Who are the faculty who will be doing the assessments and the coaching? What training do they have and what training do they need? How much will you fund their time if you do have any money to fund the program? Often funding for these sorts of programs are scarce. What administrative support do you need? What tools are available for assessment and coaching? Will you develop your own tools? Are you going to use tools that you've borrowed from another institution or from the literature? How will you vet the tools that you develop? Do you have a simulation center? And if you do, how will you pay for your use of the center? Do you have access to learning specialists? What areas will you centralize? In my experience, there's certain areas that are easier to centralize than others. For instance, in GME, you can develop a centralized program for assessment and remediation of professionalism. Coaching medical knowledge, on the other hand, may require that you have some representatives from each department who are involved, as it may be harder for, say, someone from medicine to coach a surgery learner on knowledge. And then finally, there are decisions to be made regarding policy. It's obviously important to involve the GME office and the legal counsel in these issues. So specifically, what is your remediation policy? And again, remediation means something different at different institutions. We've rewritten our policy now since we created COACH to incorporate COACH into the remediation policy. But again, this varies from institution to institution. And as I said, I think it is difficult to come up with a one-size-fits-all model because institutions are really different. I've given workshops on this at national meetings, and I'm always so amazed at how different people's experience is from place to place. So if anyone has questions about setting up a program, I'm happy to talk with you. And as I mentioned, we are in the process of building a longitudinal program at the medical school here at UVA, which has been fun and challenging. And so I'm happy to talk with people about things on the UME side as well. So with that, I just want to acknowledge a handful of people. Number one is Jeanette Gerasio, who was formerly at the University of Colorado. Jeanette and her group are really the pioneers in remediation and published their experience the year that we were beginning ours at Penn. And Jeanette and I have gotten to be friends and have worked together to do some presenting at national meetings. And she's been an immense source of help and guidance over the years. Truly talented. My colleagues at Penn, Eric Gorin, Lisa Bellini, and Jen Kogan, who were instrumental in us getting our program off the ground in 2014. Eric still runs the program at Penn, and he and I continue to work together. And then finally, my colleagues at UVA, Susan Kirk, who is our DIO, Diane Farinow, who works in the Department of GME and who have been instrumental in getting COACH off the ground, Brad Kesser, who's the Associate DIO for Wellness, Carol Zoe at Penn, who I mentioned before, Amit Shahane, who's the psychologist who works with me on COACH, and finally John Shorling, who is my mentor here at UVA and runs the Clinician Wellness Program, all of whom have been instrumental in helping me work with individual learners. And with that, I will end with my contact information. I encourage any of you to reach out with questions or to share cases. I love and always learn from talking with people at other institutions. And again, I regret that this talk is not in person because I always make these talks interactive and again, like to hear from the audience about cases and policies and things like that. So please do reach out if you have questions. And with that, I will end and say thank you again for this opportunity. Take care.